Good afternoon, everyone. My name is Priscilla Calvache. I'm the Assistant Director for Lupus Programs and Community Engagement here at HSS. I'm excited to wish you all a happy Lupus Awareness Month and to welcome you all this evening for this important presentation on navigating the transition from pediatric to adult rheumatology care. Before we get started, I'd like to begin with a few brief housekeeping rules. Participants will be muted during the presentation, but we're highly encouraging you to please use the chat box to send questions throughout the presentation. We will have time to review your questions at the end of the presentation, and Dr. Adams and Dr. Siegel will also be addressing questions that were submitted during registration. Today's session will be recorded, and all recordings will be available at HSS's YouTube page in early June. Lastly, I'd like to introduce our program evaluation. Your feedback is really important to us and really helps us to inform future programs. So we'll be sharing that link at the end of today's program, and we hope that you can spend a few minutes completing our brief survey. Now it's my pleasure to introduce our speakers for this evening. Dr. Alexa Adams is a pediatric rheumatologist at the Hospital for Special Surgery and Weill Cornell Pediatrics. She completed pediatric residency and chief residency at New York Presbyterian Cornell and pediatric rheumatology fellowship training at HSS, where she joined the pediatric rheumatology faculty in 2006. Dr. Adams specializes in the care of children and adolescents with pediatric rheumatic diseases, including childhood onset lupus and juvenile idiopathic arthritis. Dr. Adams is director of the Pediatric Rheumatology Fellowship Program at HSS Weill Cornell and is particularly interested in optimizing the transition process for young adults with childhood onset rheumatic disease and works closely with the Pediatric to Adult Rheumatology Transition Group at HSS. Dr. Caroline Siegel is an adult rheumatologist at the Hospital for Special Surgery and Weill Cornell Medicine. She completed her general rheumatology training at HSS, as well as a one-year women's health fellowship sponsored by UCB within the Rheumatology Reproductive Health Program at HSS. Dr. Siegel specializes in the care of patients with various autoimmune rheumatic diseases, including systemic lupus erythematosus and inflammatory arthritis. She conducts clinical research and quality improvement initiatives focused on preventive aspects of sexual and reproductive health care for people with rheumatic diseases and participates in a working group focused on optimizing the transition from pediatric to adult rheumatology care at HSS. Please join me in welcoming Dr. Adams and Dr. Siegel. Welcome, Dr. Adams.
Thank you so much, Priscilla. I really appreciate the invitation to speak tonight. Can you hear me okay? Okay. For everybody in the audience, thank you so much for tuning in. Again, my name is Alexa Adams, and I'm a pediatric rheumatologist at HSS and Cornell. And I want to thank everybody for joining this evening. Let's see if I can get my slides to advance. Here we go. I have no disclosures to report. So I'm going to start with a little bit of background for everybody. In the United States, there are approximately 32 million children, and about 43% of them have some sort of chronic disease. And many of these patients will have continued active disease into adulthood, requiring treatment in some form or another. It's well known that for pediatric chronic diseases, the period surrounding transition from pediatric to adult-centered care is a period of vulnerability with a risk of worse health outcomes. And these care gaps have been seen for patients with pediatric rheumatic diseases as well. So this really highlights the importance of an effective healthcare transition process for all childhood onset illnesses. But the focus of today's discussion, of course, is going to be lupus. So I'm going to start with a little bit of background on childhood onset lupus. Childhood lupus is defined as lupus with onset before 18 years of age. And this occurs in about 10 to 20% of lupus cases, although childhood onset lupus is relatively rare. As you can see, it accounts for a good proportion of the lupus cases. It's important to understand that neonatal lupus is a different disorder, which is a distinct clinical syndrome characterized resulting from the passage of certain lupus antibodies from the mother to the baby across the placenta. So that's not what we're going to be covering tonight. Instead, we're going to be covering childhood onset lupus, which is lupus occurring in children under the age of 18. And we know that childhood onset lupus has a tendency to follow a more severe disease course, with a higher risk of organ involvement, including the kidneys, the bone marrow and the blood cells, the skin, the brain, and the nervous system. Female patients do tend to be affected more often than male, but there are a greater number of male patients affected in childhood than is seen in the adult population. The cause of lupus is thought to be multifactorial, resulting from a combination of risk factors, genetic factors, and environmental triggers, which result in the loss of self-tolerance and the development of autoantibodies that result in clinical lupus. Lupus is a multi-system inflammatory disorder, and as such, there are diverse symptoms. Every case is unique, and additionally, for any individual patient, the symptoms and organs involved may vary over time. Many of the commonly involved organ systems are listed here with some of the commonly seen symptoms, but please note that this is by no means a complete list. Constitutional symptoms can include things like fever, fatigue, and weight loss. Mucocutaneous symptoms may include skin rash, sun sensitivity, hair loss, and mouth sores. Musculoskeletal involvement can include arthralgias, which is pain in the joints, arthritis, and myositis, which is inflammation in the muscles. Hematologic involvement may affect any of the blood types, causing anemia, low white blood cell count, and low platelet counts. Vascular or blood vessel involvement may include Raynaud's phenomenon or vasculitis, which is an inflammation of the blood vessels. Kidney involvement may also be seen, which may sometimes require a renal biopsy or kidney biopsy for diagnosis. The heart and lungs can be involved, with inflammation resulting in pleuritis and pericarditis. And in more severe but less commonly seen cases, there may be pulmonary embolism or blood clot and pulmonary hemorrhage or bleeding. Neurologic involvement may also occur with headache or mood changes, and in more severe cases, seizures or stroke. Given the diversity of organ systems involved, a multidisciplinary team is often needed for comprehensive management. So children with lupus may follow with a number of pediatric specialists and practitioners in addition to the pediatric rheumatology team, and these caregivers altogether form the multidisciplinary care team. Just to go over a little bit about the treatment of childhood onset lupus. Treatment is generally tailored to each patient's unique disease manifestation and symptoms, with the goal of maintaining excellent disease control while minimizing medication-related side effects. For childhood onset lupus, we use many of the same medications that are used for adult onset lupus, but with dosing adjustments as appropriate for children and adolescents. Some of the more commonly used medications for childhood onset lupus are listed here, and again, this is not a comprehensive list. Steroids are often used and may be given by mouth or by IV, and due to the numerous side effects of steroids, we make every effort to keep the steroid dose as low as is possible while maintaining disease control. We recommend Plaquenil for most of our lupus patients. Immunosuppressive medicines are often required, and these can include Cellcept, Imuran, methotrexate, Benlysta, Cytoxan, and Rituxan. Additional medicines can include antihypertensive medicines to treat high blood pressure, blood thinners if there's a history of blood clots, topical creams or ointments for skin, calcium and vitamin D to optimize bone health, particularly in the setting of steroid use or with a history of steroid use, and contraceptives for family planning, which is particularly important when taking medications which may be unsafe in pregnancy, which I know Dr. Siegel is going to address more later. It's also important to work toward optimal health maintenance, and some important aspects of this are listed here. We encourage a healthy diet as well as regular exercise. Sun precaution and sunscreen use is very important since we know that sun exposure may trigger rash and lupus flare. We recommend that patients stay up to date on all age-appropriate vaccines, with the exception of live virus vaccines if a patient is on immunosuppressive medicines. We encourage an annual flu shot and recommend the pneumococcal vaccine. We also encourage patients to follow all recommended screening to ensure reproductive health and we discuss with them appropriate forms of birth control. Mental health is, of course, a critical element of healthcare for all patients, and we screen for this and assist with referrals as needed. Family and social support is also critical, and we are so fortunate to have an incredible social work team so that we are able to offer our patients the supports, including the Charlotte DeLupas program. The transition from childhood to adulthood is what we see in adolescence, and this is by definition a period of life full of transitions. Patients are experiencing the normal changes of puberty, including physical and emotional changes. Patients may be increasingly concerned about body image, may become increasingly independent, although this does vary widely from person to person. Patients may be planning new educational and professional pursuits, may be graduating from school, starting a new job. They may form new friendships and romantic relationships, and family planning becomes an important element of healthcare. Again, there is a wide range of transition readiness. Some patients may be ready soon after 18, and some others may take more time. There are some special considerations to keep in mind for patients with childhood onset lupus transitioning to adult-centered care. Often patients with childhood onset lupus will have been with the pediatric care team for a number of years and know and feel comfortable with the pediatric rheumatology team. We may sometimes see a reluctance to move up towards adult-centered care, which is why it's so important to begin to prepare for transition well in advance. There may be a concern that parents and guardians would not be allowed to attend medical visits as they have with the pediatric team, and this may definitely be discussed on an individual basis according to each patient's preference. Navigating the healthcare system can also be complex and may seem overwhelming, particularly at a time of life when so many other changes and transitions are happening. So when thinking about transition from pediatric to adult-centered care, it's important to recognize that transition is a process and not a single event. Transition is actually defined by the Society of Adolescent Health and Medicine as the purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to adult-centered healthcare. And transition is difficult. Nobody does it perfectly. There's no one timeline or one model that works for everyone, no gold standard, as we call it. And each family, patient, and care team is unique in how they approach this and when they may be ready for transition. Certainly, communication among the pediatric team, patient, family, and adult team is critical for smooth transition. And no matter how the process is put into effect, the goal is the safe transition of every patient from pediatric to adult-centered care. Considerations as to the best time to proceed with transition over to an adult provider can include the patient and the family's individual readiness, the disease activity at that moment in time, whether the disease is very active or whether it's a period of low disease activity, the patient's educational and professional plans, where they are located and their access to care, and a number of other personal factors. It's important to begin the discussions about transition early in adolescence while the patient is still under the care of the pediatric team, and to help set up expectations for working towards transition to adult-centered care, and then working together to achieve some important milestones along the way. Beginning around age 18, we may begin to model adult-centered care, offering visits without the parent or the guardian present for all or part of the visit. We encourage young adults and adolescents to practice discussing their own care, knowing their medicines and their doses, practicing communicating with the doctor's office for things like scheduling appointments, sending portal messages, asking questions, requesting refills or other services they may need, knowing what their pharmacy is and knowing their insurance coverage, and then maintaining up-to-date contact information in the medical record, meaning maintaining the patient's own contact information in the medical record, as well as the family's, if that is what the patient chooses. Got Transition is a national resource center on healthcare transition, and they have a very nice website with transition materials and resources. And this group has defined the 6 core elements of transition, which include the transition policy, tracking and monitoring, assessing transition readiness, transition planning, the actual transfer of care, which is just a part of this process, and then transfer completion. And here you can see the recommended timeline. So you can see that around age 12 is a good time to start discussing transition and making patients and families aware that this is going to be something we're working towards through adolescence. As we progress through adolescence, we work towards transition to an adult model of care with the goal of transferring to the adult medical home between 18 and 22 years. And then this is followed by a phase of integration into adult-centered care. I like this graphic also from Got Transition because I think it's a nice pictorial representation of this as a process. Again, there's no gold standard of how to approach transition. And again, the overarching goals are the same, which is the safe transition from pediatric to adult-centered rheumatology care. Here at HSS, we are fortunate to have both pediatric and adult rheumatology in one location. We have a transition group consisting of pediatric and adult rheumatologists, nurses, and social workers, each of whom serves a very important role in facilitating the transition of young adults from pediatric to adult-centered care. And we've worked to hone the transition process over the past few years, and I'm so grateful to be a part of such a fantastic team working to support our patients as they transition their care. Oops. Our process generally includes an assessment of transition readiness starting in early adolescence. Nursing and social work are really integral to helping assess readiness and to lending support, including setting expectations for young adults as they move to the adult rheumatology practice. Nursing and social work support leading up to and following transition is tremendously helpful to the process, and we have had wonderful continuity in that our Charlotte Lupus social worker supports both the pediatric and adult rheumatology teams and can provide really important continuity of support during the period of transition. We take a multidisciplinary approach to transition with the pediatric and adult care teams working together on the process from start to finish, and then ensuring closed loop communication once the process is complete. So I want to thank everybody for your attention. I'm going to now turn this over to Dr. Siegel, who's going to address more about adult rheumatology and the transition process from the perspective of the adult rheumatology team. Thank you. Stop sharing.
Right. Am I sharing my slides correctly? Yes. Okay.
You're good to go.
Great. Thank you. Thank you, Dr. Adams. Thank you, Priscilla, for the invitation to be part of this important talk. And thank you, everyone, for attending and for your attention. So I'm going to be talking about the transition process from the adult rheumatology perspective, as Dr. Adams said, and I'm really going to focus on trying to empower you as the young adult transitioning to the care of an adult rheumatologist and to adult-centered care as a model by focusing on really educating about lupus and how we think about lupus as adult rheumatologists and how we try to partner with our patients to really optimally manage this condition for each individual. I also have no disclosures. So some of this also may be a bit repetitive. I'll go through some of the repetition intentionally because I think some people were trickling in late, and also to just reinforce, but I'll also spend a little more time on different aspects. So in terms of some basics, as Dr. Adams mentioned, females are more likely than males to have lupus, and this ratio, this differential sort of increases in the adult years. So there's a 3-to-1 female to male ratio in kids with lupus, and this becomes somewhere on the order of 7 to 15 to 1 female to male ratio in adult onset lupus. Most people with lupus are diagnosed between the ages of 16 and 55, which is a broad range, of course. And lupus it can be more severe in males as opposed to females, and also in childhood onset versus adult onset disease, more commonly affecting the kidneys and other vital organs in these groups. The takeaway that I will intentionally re-emphasize is that lupus is, of course, a chronic condition, and it really can manifest differently for each affected person, and even within an individual can change considerably over time. So there's no, everyone is unique with lupus, and our approach to management and partnering with patients is individualized as a result. So how do we think about general lupus assessment and management? So I'll talk a bit more about this in subsequent slides, but Dr. Adams also alluded to the antibodies that can be present in the blood tests of patients with lupus, and this can vary from patient to patient and also in a patient over time, and really give us some helpful information about potential risks and complications and considerations for a given patient. And then, of course, we think about what are the symptoms that a given patient has experienced or is experiencing, and what organs have been involved for the patient in front of us. How active is the disease? And I'll spend more time talking about what we mean by this concept, but it's really sort of the current status in terms of how the current status of the disease, as opposed to then we also think about, is there any disease or treatment related damage? And this concept really refers more to sort of injury to the body that can result as a consequence of prior activity, or in some cases as a result of medication. So these are two important concepts that we think about in assessing the status of lupus. And then, of course, what medications are needed to control the disease activity on the one hand, and then also to prevent accrual of further disease damage over time. And to help sort of understand and manage expectations about what it will look like to partner with your adult rheumatologist over time, we generally recommend routine follow-up every 3 to 6 months. And this is even in cases where symptoms are well controlled, or there are no symptoms and medications are stable, to at least check in every 3 to 6 months. And then, of course, more frequently when needed, depending on what's going on. And these routine visits generally involve, of course, reviewing symptoms and medications, any barriers to taking medications, any side effects that have come up, and also checking blood and urine tests. Okay, so I want to go through the various autoantibodies, and it's a lot of jargon, and it may or may not apply to a given patient, but just to provide some familiarity with these terms that then, you can think about on an individual basis with your rheumatologist. So the ANA test is the anti-nuclear antibody test that many may be familiar with. It's the initial screening test done to assess for lupus generally in clinical practice. And it is not specific for lupus, so it can be present in people who don't have lupus, but almost everybody who does have lupus will have a positive ANA test at some point in their disease course. The anti-double-stranded DNA test, or the DNA antibody, is also associated with lupus. It is not present by any means in everyone who has lupus, but when it is present, it's highly associated with this diagnosis as opposed to others. And then of patients with lupus who have this antibody, there is an association with lupus nephritis or kidney involvement, although not everyone will have kidney involvement. And with this antibody, the level, sort of the degree of positivity tends in some patients to correlate with the degree of activity of the disease. So not just positive or negative matters, but also the number at a given time point. The anti-Smith antibody is present in a subset of patients with lupus and also can be associated with kidney involvement, though not in everyone. And then there's something called the anti-Rho or SSA, Sjogren's syndrome associated A antibody. And this is present in many patients with lupus, but it's also sort of the defining antibody of a different diagnosis called Sjogren's disease. And sometimes these conditions can overlap, or symptoms of them can overlap. This antibody is also associated with neonatal lupus, which Dr. Adams had alluded to, which is different from childhood onset lupus, and is a condition that is can be present in babies of mothers who have this antibody during pregnancy. And I'm not going to spend much time on this for the purposes of today's talk, but just again, to give you some familiarity. And then the presence of this antibody also is associated with an increased likelihood of cutaneous lupus or skin rash in lupus. Anti-LA or Sjogren syndrome B antibody is often present in people who also have the Sjogren syndrome A antibody and has the same potential associations. And then lastly, anti-RNP or ribonucleoprotein is present in a subset of patients with lupus. And when it's present at high titers, it's actually characteristic of a lupus-like condition called mixed connective tissue disease, or MCTD, which is an overlapping syndrome that carries features of lupus and other autoimmune rheumatic diseases as well. But it also can be present, this antibody, in patients who just have lupus. And I wanted to spend a little bit more time on antiphospholipid antibodies because these can be a source of a lot of confusion, understandably. So people with lupus may often have antiphospholipid antibodies in their blood tests as well. And this typically refers to 3 major categories of antibodies, which are called lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein 1 antibodies. And when any or all of these antibodies are present in the blood at a certain level, above a certain threshold, with persistence over time, this is associated with an increased risk of blood clots and certain pregnancy complications. Having these antibodies alone is not the same as having a diagnosis of antiphospholipid syndrome, or APS. This is a diagnosis given to people who have these antibodies, again, at above a certain threshold and with persistence, and have had prior blood clots or associated pregnancy complications. And this can overlap with lupus, but it also can be a diagnosis independently of lupus. And APS is typically treated with blood thinners. Okay. So I mentioned disease activity as a key aspect of our assessment on a visit-to-visit basis. And what do we mean by this concept? So this refers to assessing, first and foremost, the patient's symptoms, and that can involve sort of interrogating whether the symptoms of previous or typical flares for that patient are recurring or are present. And this can be really any number of things. As we've said, each patient's symptoms are different. Each patient's organ involvement may be different, but symptoms can include fatigue, rash, joint symptoms, hair loss, mouth or nose ulcers, chest pain or pain with deep breathing, and then in rarer cases, neuropsychiatric symptoms like significant confusion or behavioral change or seizures. And then we think about these symptoms in the context of blood and urine tests that will be checked generally on routine visits and also when symptoms are present. And so the key lab tests that correlate most with disease activity are going to be blood cell counts. So low red blood cells, low white blood cells, low platelets can all be markers of active disease. And then general markers of inflammation, which are called ESR and CRP. And then there are more lupus-specific markers of inflammation that we tend to look at, which are called complement levels, and low complement levels in particular can be markers of active disease. And then again, the anti-double-stranded DNA antibody levels, the titer, the degree of positivity at a given time can in some patients correlate with active disease. And then for patients who have kidney involvement, we also look at the creatinine level in the blood. I mean, we look at this in all patients, but it can be a marker of active kidney disease when the creatinine level in the blood is elevated, the protein or certain blood cells, red blood cells, white blood cells, or something called casts are present in the urine at elevated levels. Okay. So moving on to treatment considerations. So this is really a slide that this figure is meant for a rheumatologist. And so it's not my intention that, we'll come away with a detailed understanding of everything here, but this is to give you a pictorial representation because I think it's helpful to see that there's no clean algorithm that applies to every patient with lupus in terms of how we approach treatment. because again, our treatment is really individualized to the patient in front of us, depending on what manifestations of disease they have. And so here, this gives a gestalt of how we think about treatment. And this is specifically, this comes from a publication from EULAR, which is the European organization for rheumatologists. And this is for non-renal lupus, so everything but kidney involvement. And so it's broken down in terms of the severity of disease, so mild, moderate, and severe. And as you can see, there's various considerations, and I'll put up on another slide the actual names of these medications and give some more helpful takeaways. But there's overlapping and variable considerations of different medications that might be used for these different degrees of severity, depending on the patient and depending on many other considerations. So that's the main point of this. And then on the side here on the left, there's other measures to consider that I'll spend some more time on as well, beyond pharmacologic treatment in terms of non-pharmacologic means to optimize health and optimize lupus activity. And then the targets are really focused on achieving ideally remission, meaning no symptoms, and stable medication use with low or no dose of prednisone or steroids, or at the very least, what we consider low disease activity. So minimal symptoms with stable use of medications and not requiring significant steroids. And this comes from the same publication, and this one is focused on lupus nephritis, so kidney disease specifically, which has its own sort of treatment paradigm. And here we think about the initial treatment when the lupus nephritis is first active or flaring, and then subsequent or sort of maintenance therapy. And so there are some medications that are used in both contexts, but there are also some different considerations at that early and active phase compared to sort of maintaining disease control over time. And again, I'll spend more time on specifics, but I just wanted to share the paradigm. Okay. So hydroxychloroquine, which is also known as Plaquenil, is really the standard of care as background therapy for all patients with lupus, except in rare cases where there may be contraindications. So this is the exception to the rule that treatment decisions are individualized, because really, as a general rule, we do recommend Plaquenil for all patients with lupus. This is an immunomodulatory medicine, not immunosuppressive, so it doesn't increase the risk of infection or have other associated side effects that we think about with immunosuppression. And it has been shown to reduce lupus disease activity and also flares. And it's also been shown to have longer term benefits, including reduced overall mortality in patients with lupus. So it's not just indicated for active symptoms, but we really have seen that it has long-term benefits with continued use. And then another benefit, especially for young women taking hydroxychloroquine, is that it is safe to take during pregnancy and actively recommended for lupus patients to take during pregnancy. There are some potential side effects and toxicities as of all medications, and one that we always emphasize just for awareness, even though it is rare, is something called drug-induced retinal toxicity that occurs in less than 2% of patients taking this medication for up to 10 years. So it's rare. And with dosing, sort of abiding by dosing recommendations when possible, based on body weight, and also routine ophthalmologic screening. So seeing an ophthalmologist generally once a year for patients who are on Plaquenil, this risk is significantly decreased. And early signs of this toxicity can be picked up before it would have any impact on vision or have any clinical consequence. Okay. Glucocorticoids or steroids, which usually refers to prednisone or methylprednisolone, we use to control disease activity. And our goal, as Dr. Adams mentioned also, is to use the lowest effective dose for the shortest duration needed. There are situations where short-term higher doses are needed, typically for moderate or severe disease. But again, we try to be very thoughtful about our use of steroids, because there are many potential adverse effects, especially associated with cumulative exposure over time and higher doses. And these are listed here. They include infection, weight gain, high blood pressure, high blood sugar, mood and sleep disturbance, stomach ulcers, low bone density, osteonecrosis, muscle injury, and adrenal suppression. And then there are many immunosuppressive medications available for the treatment of lupus, and I'll go through them quickly. And again, just to familiarize you with the names, but of course, this would be a longer conversation on an individual basis about specific indications for a given patient. And I've broken them down here in terms of mode of delivery, because I think that's helpful to think about as well. So there are various medications that are available as pills, and these are listed here. So azathioprine or Imuran is an option for mild to moderate disease, and also can be a therapy used in lupus nephritis for maintenance therapy. And one benefit of azathioprine is it's also compatible with pregnancy. Methotrexate is an oral medication that is especially helpful for skin and joint symptoms. Mycophenolate or Cellcept or Myfortic are the other names for this medication, are good options for moderate and severe disease, including for lupus nephritis. And methotrexate and mycophenolate are not compatible with pregnancy, so this is often an important consideration. And then tacrolimus is an option for moderate disease, often thought of as add-on treatment for lupus nephritis, and it is compatible with pregnancy as well. And then voclosporin, which was recently FDA approved as a medication available for moderate disease, recently FDA approved, I should say, for lupus nephritis specifically as add-on treatment as well. Belimumab or Benlysta is available both as a subcutaneous injection and also in an infusion form. And this is a treatment available for moderate disease and can also be used as add-on treatment in lupus nephritis. And then there are a few medications that are available only as infusions, so they would need to be given in an infusion center. And these include anifrolumab, which is available for moderate disease and especially shown to be helpful for skin symptoms like rash. And then cyclophosphamide or Cytoxan and rituximab or Rituxan, which are really reserved for severe disease. Okay. And then again, there is an important role for non-pharmacologic treatment and also preventive care in lupus to really optimize one's health. So this includes sun protection, which is really important, and we emphasize with our patients, exercise, avoiding smoking or stopping smoking. And then depending on the patient and the specific risk factors or comorbidities, we discuss management of these, and this could be in conjunction with primary care doctors and other doctors as appropriate. So blood pressure, cholesterol, obesity, and low bone density are important considerations. We also think about vaccinations, and of course, many of these vaccinations are recommended in the general population with or without lupus, and specifically everyone is recommended to get the flu shot, the COVID-19 vaccine, and the HPV vaccine series. But we do, especially emphasize this in the context of having lupus because of the inherent sort of immune dysregulation. And then specifically for patients who are actively taking immunosuppressive medications, even younger than the ages that would be recommended in the general population, anyone who's on immunosuppression with lupus, we would recommend the pneumococcal vaccine series and herpes zoster or shingles vaccine, which otherwise in the general population are recommended by specific age groups that are different. And then lastly, we think specifically about preventive sexual and reproductive health care, and we talk to our patients about this. And this includes pap smears, starting at age 21, which again are also recommended in the general population for HPV and cervical cancer screening, but there are some differences in certain cases in terms of the frequency of this procedure in the context of lupus, and especially with immunosuppression. And then also contraception and family planning, which I'll spend some more time on. And so other than general considerations in lupus, we emphasize the importance of contraception because many medications, as I've mentioned, that are commonly used to treat lupus are teratogenic, which means that they can harm a developing fetus. They're not safe to take during pregnancy. And then also, regardless of the medications used, when lupus is active, the risks of complications during a pregnancy are higher. And so because of both of these considerations, the use of effective contraception for pregnancy prevention when pregnancy is unwanted or would be medically ill-timed, or for patients taking medications that wouldn't be safe to continue during pregnancy, the use of effective contraception is really critical. And thankfully, many contraceptive methods are perfectly safe and effective for people with lupus. There are some specific considerations and scenarios to consider if you have lupus. For example, if the disease activity level is high, or for patients who have antiphospholipid antibodies or defined antiphospholipid syndrome, we recommend avoiding estrogen-containing contraceptive methods. And then people with lupus in general, regardless of disease activity and regardless of APL or APS, should avoid the estrogen-containing patch. And this is because it really delivers a higher dose of estrogen. And there's a concern that it may increase the risk of disease activity itself, and also thrombotic risk or risk of blood clot. And then CellCept or Myfortic, it's important to be aware that these actually may make birth control pills less effective. So if that's the chosen form of contraception and you're taking one of these medications, it's recommended that you use a second form of contraception, such as condoms, or consider an alternative that's more effective, such as an IUD or a subdermal implant. And so this is just to make you aware of this really helpful resource. And these resources are made available through a partnership with the American College of Rheumatology and an organization called Bedsider. So these are contraception recommendations summarizing a lot of what I just said, geared toward patients that are specifically for patients with rheumatic disease. And I think one takeaway that I always like to emphasize on the top left is that the most effective contraceptive methods shown here, so IUDs and the subdermal implant, are also safe for all patients with rheumatic disease, including lupus, including APS, with really no caveat. So that's sort of a win-win if those are options for you. And then otherwise, there are some considerations in this category that are safe for most, which include the Depo-Provera shot, the NuvaRing, and combination estrogen-progestin pills. Again, with antiphospholipid antibodies, these wouldn't be recommended. And then the patch is shown here where it's generally avoided in lupus or patients with positive antiphospholipid antibodies, regardless of disease activity. So this is just helpful to sort of have in your back pocket or reference when appropriate, because it sort of puts it all together. And then this is focused specifically on emergency contraception. So what birth control can I take after sex? So this is, again, for patients with rheumatic disease. And there are three major forms of emergency contraception listed here. IUDs, which can function as emergency contraception and then have the benefit of ongoing contraception. And then prescription emergency contraceptive pills, which can be used up to 5 days after unprotected sex, but need to be used with each incident. And over-the-counter emergency contraception pills, which are nice because they're readily available over the counter, best to use within 3 days, but may work up to 5. And again, of course, need to be used every time. Right. So I want to spend a moment on lupus and fertility because this question comes up a lot. And as young adults start thinking about family planning in particular, this may be on your mind. So reassuringly, most research does not support the idea that lupus itself causes infertility. There are, however, many factors related to having lupus that may impact one's ability to get pregnant or ultimately lead to decreased family size. And these are sort of listed here. And this can include advanced age. And sometimes this comes into play if patients are diagnosed right around the time when they might be thinking about getting pregnant, or disease is active, and disease-related factors may delay pregnancy or conception. Other psychosocial factors, menstrual irregularities, which may be associated with lupus, or medications used to treat lupus, like steroids, cytotoxic medications like Cytoxan, other medications, antiphospholipid syndrome, and potentially local autoimmune effects. So autoimmune impacts on the reproductive organs themselves. Cyclophosphamide or Cytoxan can impact fertility. However, it depends a lot on the cumulative dose over time, and older age at the time that it's administered it also confers additional risk of fertility impairment. And there are some treatments that can be given if timed appropriately to potentially decrease this risk if Cytoxan is being given in a reproductive age woman. And then NSAIDs, which encompasses medications like Motrin, naproxen, that are commonly used for joint pain and other symptoms, can lead to a temporary reduced ovulation, and so impact conception in that way, but doesn't have a lasting impact. And then high-dose steroids can also temporarily interfere with ovulation and menstruation and impact conception. Okay. So in terms of family planning and pregnancy considerations, women with lupus do have an increased risk of certain pregnancy complications, including miscarriage, preeclampsia, growth restriction, and preterm delivery. And there are several established specific risk factors to consider because, again, every individual situation is different. So, of course, medications that are teratogenic or toxic to a fetus increase the risk of miscarriage, and then also certain congenital anomalies in the baby. Having active disease or having current or previous kidney disease are associated with increased risk of some of those complications. The presence of antiphospholipid antibodies is also associated with an increased risk of adverse pregnancy outcomes. And then the Sjogren's associated antibodies, as mentioned before, are associated with an increased risk of neonatal lupus in the infant. But the good news is that many women with lupus really can have safe and successful pregnancies. And this is especially true when planning is able to take place. And so when disease is well controlled, so low disease activity or remission on medications that can be safely continued during pregnancy for at least 6 months prior to conception, this is sort of the ideal scenario. And also during pregnancy, we always recommend close monitoring by the rheumatologist and also by a high-risk obstetrician, and they can work together to sort of optimize outcomes for mom and baby. Okay. I think I touched on the medications that are safe or not safe in pregnancy. This is also a helpful resource to be aware of that is comes out of Duke lupuspregnancy.com. So it's an easy website to remember that has a lot of helpful resources, including this one about pregnancy and lupus. So I want to leave time for questions and discussion, but I'll end on this important note that, in general, I think the most important aspect both of the transition process and then ongoing success with managing lupus with your rheumatologist and your other doctors is open communication. So really, you should think of yourself as the central member of a team with your doctor, with the doctors that are involved in your care. And trust and open communication really make it possible for us to adequately address your concerns and make sure that you're being cared for. And so always be sure to discuss active symptoms, ask questions, share any concerns about the disease, the medications, as they come up so that they can be addressed. Thank you for your attention and happy to address any questions or comments.
Thank you so much, Dr. Siegel and Dr. Adams, for this both comprehensive presentations. At this time, we're going to turn to our question and answer portion of the program. So we encourage you to please use the Q&A box icon or the chat box to submit your questions. And we're actually going to begin with some of the questions that came in at registration. So our first question is, at what age is normally the transition time? And are there any other doctors that should be added to the patient's team as they progress from pediatrics to adult?
I can take the first crack at that. Thank you for the question. That's a really good question. I think I touched on that to some extent. Again, I think it's really important to remember that transition is not just, oh, you've reached this age, it's ready, your time, it's time to transition. It's really a process, and it's not just an event, it's a whole process. So getting ready for transition, preparing for transition, choosing a time together with your care team and your family or your partner, whoever is a part of your support system, to say, okay, I'm ready to make the move to adult-centered care. And we're, keeping in, like Dr. Siegel was just saying, keeping in close communication with your care team is very important around this issue. We generally, say, a period where the disease is under good control, where, a patient knows that they're in a location where they're going to continue to be living for a period of time, and when the patient feels ready to make that transition. We, like I said, start discussing transition in early adolescence and sort of work towards that over the course of adolescence. Typically trying to begin modeling adult-centered care around age 18, but that doesn't mean that at age 18 you necessarily have to make the transition over to adult care. Some people may make that transition shortly after 18, some at 19 or 20, and some even in their early 20s. It just really depends on the individual patient, the team, and the location.
Great. Thank you, Dr. Adams. So we have another question similarly. Does my pediatric rheumatologist speak to my new adult rheumatologist? I always find it hard having to repeat my story and start with someone new, especially if I already have a relationship with one doctor.
I think that's a really good question too. I won't talk as long this time, so Dr. Siegel can jump in as well. But I think we both kind of emphasized in our presentations that communication is really important. So no matter what phase of the transition process you're in, it's going to be important, communicating with the pediatric care team and the patient, communicating with the adult care team and the patient, and then the pediatric care team and the adult care team communicating together to bring everybody onto the same page, to review the history, and certainly to answer any questions about the patient's disease course. But you're right, it can be frustrating to have to repeat the history so many times to so many different people. So, we try to help with that. Dr. Siegel can speak a little more to how that feels on the adult side, I think, than I can.
Yeah, it's a great question, and it comes up a lot. And I think there's a couple of things I wanted to add. One, so just like it would be if you were going to see a new doctor and not specifically to transition, it's always really helpful. So we have the benefit at HSS of being in one place and being part of the same system, so we can see the notes, see the lab tests that have been done before, and easily communicate with each other because we're on the same location. That's not often the case. And so especially when that's not the case, trying as much as possible to obtain those records from your pediatric rheumatologist, ideally in advance of that transition, or at least soon after the transition, to help provide all of the materials that go along with the transition of, if you were ever hospitalized, have hospital records, or notes from your pediatric rheumatologist are really helpful to have. At the same time, I always tell my patients, even when they give me all the materials they have and I spend the time reviewing it, that I still want to hear the story from them at their first visit. And I think that while that sometimes can be challenging and frustrating and feels like repetition, it's important for a few reasons. One, because I think you always learn different things when you hear the story from the patient or the family themselves. And also it's helpful to know sort of where you're coming from in terms of the experience, and you can't always glean that from the notes. And so I think both of those pieces, those sources of information, are really important. So that helps ease the frustration at all. There is some value also in the repetition, I think.
Thank you so much. Now, this next question is for you both. Can you talk about the key differences in approach between pediatric and adult rheumatology care?
So I think there are some, you can tell by the fact that some of our slides were slightly overlapping, that there are certainly some similarities in how we approach the care of patients with lupus. Pediatric rheumatologists take care of children, from early childhood up until late adolescence and young adulthood. But we are often meeting the patients in young adult or in earlier childhood or school age children, and they're coming to the appointments with their family, with their guardian, and often, get very used to that. And so do we, so I think as we follow along the process towards transition, we do try to have patients take a little bit more ownership, understand how to talk about their illness, understand how to talk about their symptoms, to ask questions of the doctor, or the nurse or the social worker, whoever is working with them in that moment, and to make sure that they learn to advocate for themselves. We do allow parents to remain in the visit, or guardians to remain in the visit, up until 18, and certainly beyond 18, if that is what the patient prefers. And then I think we do try, as patients reach age 18, certainly we need permission to discuss any healthcare related issues with family members. but that can be done with the patient's permission. But we also try to empower each patient to begin taking that ownership, if that answers the question.
Yeah, I think I don't have too much to add there. I think that when on the adult side, the general approach to managing lupus is the same, like Dr. Adams said. And it's just sort of trying to help facilitate that process of taking more ownership generally over your management of your health as a young adult. And so we still, in our practice, and I think in general, family members of adults are often present in the visit too. So it's not that your parents can't be there if that's what you prefer. We do try to make a point of having at least a moment, a couple of minutes alone with the patient. And that's the case also. I try in general, whether it's a young adult patient or otherwise, if someone's visiting, because sometimes you want to share something without the patient in the room. So we try to just normalize that. But then otherwise, family members can certainly be involved, but we do encourage patients to be the ones sharing the information, or at least having that opportunity to share the information and being sort of comfortable with the medications that they're taking and the follow-up steps that need to happen between appointments. And that can be a gradual process because it's not always, it's not easy when you're making that transition in general. But over time, sort of taking more ownership and responsibility for those steps that need to happen, like calling to schedule the follow-up appointment, calling to follow up on a referral to a specialist, making other appointments that are recommended, and then reaching out proactively if there are symptoms or questions or problems that come up, even logistical problems like refills, so learning that over time, you instead of your guardian or parent would be the one to say, oh, I'm running out of my medication, and not wait for the appointment that may be coming up in 3 months to let the office know. Things like that just, easier with practice. But our general approach is the same. It's just sort of easing into that role of being the primary person that children aren't expected to do.
Thank you so much. And our last question for the evening is, how can telemedicine and technology be leveraged to support transition care for young adults with rheumatic diseases?
Sorry, I can't. Okay, can you hear me?
Yes.
That's a very good question. Definitely, we have been continuing to implement telemedicine as an addition to sort of our care model ever since we sort of first started using it in 2020. I think that first, I do like to see patients back in person. That is for sure. And I think particularly in rheumatology, it's hard to get a real sense of the physical exam without an in-person visit. So, that being said, I do think that some telemedicine visits can be woven in, especially if patients are on stable medications and have stable symptoms and stable disease. Sometimes having a check-in on telemedicine can be very helpful. We do recognize that, young adults and adolescents are very busy. They have educational commitments, they have extracurricular commitments, they have professional commitments, jobs. It's not always easy to take off. And sometimes this can be something that's very helpful in, trying to maintain those schedules. Let's see if Caroline has anything else.
All I'll add there is, I also prefer, and I require for a first visit that I see a patient in person, but not everyone does. But then generally it's an option to do a telehealth follow-up when appropriate. But I always also emphasize the importance of coming in, especially if symptoms are active or medications have recently changed, because then it can be really important to see the patient in person. But I think this is also a really important thing to ask about when you're making the transition, if you have the option of different providers, because it really varies practice to practice how telehealth may be incorporated and sort of what options are available. And so it's now an added consideration among others when you're trying to find the right fit for your care.
Thank you so much, Dr. Siegel and Dr. Adams, for sharing your expertise on this important topic. This concludes our program for this evening.